You're listening to the Prehospital Care Podcast on the Medics Academy Network.
Welcome back to the podcast. I'm here with colleague, friend, and Dr. Sarah Spelsberg. She's back joining with me to unpack some of her fantastic blogs she's written, which we're going to include in the show notes. Sarah, welcome to the podcast.
Thank you so much for having me. It's an honor to be here.
Sarah, I wonder if we could just tackle this blog today, which is a fantastic piece, and it's really titled Not Really an Asthma Attack. So, the piece really speaks to atypical presentations. As a 41-year-old male rushed into the ER with what was reported as a severe asthma attack. I'm going to let you take it from there, actually. Could you just maybe unpack the incident?
Absolutely. So I was working out in the Aleutian Islands in the Bering Sea off the coast of Alaska, and we got a call from a fishing vessel saying, we have a guy with a severe asthma attack. We've been using the inhaler. He's not improving and he's really in distress. And so they came in a private vehicle. So I met him in the parking lot within a wheelchair, and we got him out of the car into the wheelchair, and he was kind of leaning forward and in clear respiratory distress, and on auscultation, like serious wheeze, like very tight sounding lungs, very wheezy lungs. Like it was easy to believe that, yes, this man is having a severe asthma attack. And he'd had a recent upper respiratory infection, maybe like 2 or 3 weeks prior, and had like a little bit of a lingering cough, but other than that was back to work, back on the fishing vessel. And so he can't even speak at first. He's in so much duress. He's like nodding yes or no, and he can't even speak. I get him on a nebulizer and get him some steroids, and slowly he starts to breathe a little bit better. His oxygenation starts to improve a little bit, to a point where he pulls off his mask and just says, "My chest hurts," and puts it back on. And it's, well, okay, well, that your chest hurts, so that unpacks another set of things that are going to happen expeditiously. So we got an EKG quickly, which we would have gotten anyway, but the first priority was his airway, of course. So we get the EKG, and he has just textbook diffuse ST elevation. And I'm thinking, oh my Lord, this guy has pericarditis. This is big, because we're in the middle of, we're an island in the middle of the ocean, and we have to have a medevac come take people to tertiary care. And then I pulled out my ultrasound and I took a look, and he also had like a pericardial effusion. And so then I'm thinking, this guy has pericarditis. He might tamponade. Like, are we going to have to do a cardiocentesis? And my rule out there is I don't poke holes if I don't need to. I'm not going to poke a hole in you unless I really think I need to. And like, I'm not going to take your airway unless I really think I need to, because medevac might be delayed. I might run out of sedating medication. You have to really think about what you're doing. And if the patient is tolerating it, then we kind of pump the brakes and try to be more judicious about our interventions. So we gave him anti-inflammatories. The steroids definitely helped, and we got him to a point where he was more comfortable. And I was arranging for medevac, and he and I were talking about it. And I said, listen, if you become unstable, this is what I'm going to do. I'm going to have to go in and pull some of this fluid out from off your heart, from around your heart. And I said, but if you stay like this, we'll just ride it out where you can get to a real hospital where they can pull off, a trained cardiologist can pull off the fluid for us. And that is ultimately what we were able to do. But it just, the lesson for me was, don't anchor in what the patient thinks it is. Don't anchor in what you think it is. Because he was having an asthma attack, but he also had pericarditis and a pericardial effusion. And that's really scary in such a remote area like where we were.
Yeah, absolutely. And to your point, around these atypical presentations, is that there is a severe anchoring bias, as you said, when you see something, at a presentation, and especially when they themselves are telling you that that's the presentation. Before we hear the piece, because it is a fantastic piece that we're going to hear in AI format, just could you speak to any sort of post-blog thoughts, you speak to in the piece around just having further training around atypical presentations, just to get clinicians away from that anchoring bias from maybe just being one presentation. Could I get you to speak to just that training piece?
I think for me, how this has changed how I approach things and for training is have a wide differential for shortness of breath. And then in your mind and in your workup tab, say it's not a pneumothorax because the chest x-ray is clear. I don't see a consolidation, or the lung ultrasound doesn't look like there's a pneumonia. I would say have a wide differential for chest pain, shortness of breath, and then in your thought process, actually go through, this is why it's not pneumonia. This is why it's not a pneumothorax. This is why, oh shoot, that actually is pericarditis. And so that's the thing is I think don't, if we always cast a wide differential and then systematically rule each of them out with the appropriate testing, we won't miss these things.
Yeah, I think that's a powerful pivot actually, Sarah, and it reminds us to that no one is ever beyond the pale to kind of be sidetracked by some of these red herrings actually, and in the black swan events. But I think, and also to your point around, being able to in the piece to being able to just take 5 minutes, start from a diagnosis of exclusion, and also share the mental model if you can. We are just speaking offline about sharing, diagnoses and resourcing the wider team to be able to just to bounce things off and actually reaching back. And two brains are better than one sometimes, just to get a cohesive plan together for these kinds of patients. But listen, it's a fantastic piece. You're just about to hear it in AI format. Sarah, thank you for your time.
Absolutely, Owen. Nice to see you. Thank you for having me.
Welcome back to the deep dive. Today we're jumping into a really high-stakes medical case. It all comes down to this one fundamental truth in medicine.
Yeah, that sometimes the loudest symptom, the one that's screaming at you, is really just a distraction.
Exactly. It's hiding the real life-threatening crisis that's happening just underneath the surface.
It's the ultimate test of clinical judgment, really.
Right.
We're going to be looking at what happens when a very common symptom, in this case, severe shortness of breath, is actually masking a rare and critical heart condition.
And for you listening, this deep dive is all about understanding how expert clinicians connect these, non-textbook clues in real time under immense pressure. Our source for this is a reflection from a PA, a physician associate, working in a really remote setting. It was shared by Dr. Sarah Spelsberg on RogueMed, and it's just such a candid look at that pressure.
The pressure of being the highest level of care available when a patient's body throws the ultimate curveball. So the mission here is to really dissect the critical pivot points in this case. We have a 41-year-old man who presents in extremis.
Right.
And what looked like a devastating severe asthma attack turned out to be something else entirely. Viral-induced pericarditis. That's inflammation of the sac that surrounds the heart.
So we're going to trace the steps that led the medical team to look past the lungs and focus critically on the heart.
Exactly.
Okay, let's unpack this. We should probably start right at the beginning, the moment that call came in.
The urgency of it all.
Right, and the setting here is so important. We're talking about a small, remote clinic on an island.
Not a big city hospital.
Not at all. And the emergency call was very specific. Severe asthma attack. The patient, a 41-year-old guy, had a known history of asthma. He'd already used his own rescue inhaler multiple times.
And got zero relief.
Zero relief. And had been getting progressively worse for several hours.
That's such a classic setup for misdirection. When a patient comes in with a known history and what look like textbook symptoms, your brain is already leaning in one direction. The bias is set.
Yeah, and you have to picture the logistics of this little island ER. There's no ambulance crew bringing him in.
No, he was rushed in by a friend right from his fishing vessel.
And the visual, the description of his arrival is just terrifying. He was immediately flagged as severely ill. He slumped forward in a wheelchair.
And the clinicians described him as working hard as anyone has ever seen just to breathe tiny breaths.
He couldn't speak, could barely even nod. And this is crucial. He could not lay down flat.
And those physical signs, they were so key, but they're also a barrier. The labored, shallow breathing, the constant wheezing, it was so dominant, so loud, that it was creating a physical barrier to diagnosis.
How so?
Well, the clinician actually noted that she could barely hear distant heart sounds over the sheer noise of his breathing. The wheezing, the exhaustion, the pale skin, the racing heart. It all just screams respiratory failure.
So, okay, given this is an immediate life or death situation, the team just acts on the most obvious problem first.
You have to. You have to treat what's killing him right now. So while they're getting vitals and starting labs, they launch the standard aggressive treatment for what they think is status asthmaticus.
What does that involve?
It's a powerful combination. He gets a high-dose steroid, which is IM dexamethasone, and he's immediately put on a nebulizer.
Right.
The steroid works systemically, all over the body to rapidly shut down that massive inflammation that's squeezing the airways. And the nebulizer, of course, shoots a fast-acting bronchodilator right into the lungs.
So that combo is designed to break that cycle of spasm and inflammation, and fast.
Very fast. They were honestly prepping for the worst. They thought they might have to intubate him because he was failing so quickly.
Now, if this really was just asthma, that combination should have worked like a charm. But this is the first critical failure point.
It is.
After they gave him the treatment, his breathing improved only, scantly. The change was minimal.
And that minimal response is a flashing red light, a huge one. A severe, life-threatening asthma attack that gets that level of treatment should respond decisively.
It should get better.
It should get much better, quickly. The fact that he was still in profound distress, still fighting for every single breath, it means the engine of the problem wasn't primarily in his airways.
Even though the airways were obviously affected.
Oh, clearly affected. But this forces the clinician to stop and ask, okay, wait, what else? What else causes this kind of distress that doesn't respond to asthma treatment?
And this is where the whole story just pivots, because that slight, almost unnoticeable improvement was just enough.
It was just enough to give them the one piece of information they needed.
The patient had been, just clutching the nebulizer mask, totally unable to communicate. But after that little bit of relief from the steroid and the neb, he had just enough energy to pull the mask away for a moment.
For 1 second. And he utters 3 crucial words, then collapses back onto the mask.
My chest hurts.
My chest hurts, and suddenly everything changes.
The focus immediately shifts from a purely pulmonary crisis to, a possible cardiopulmonary crisis.
Yeah.
But hold on, I get that chest pain is crucial, but couldn't that just be from, the strain of coughing so hard?
That's a really sharp question, and that's what separates a quick differential diagnosis from a complex one. Yes, it could be musculoskeletal pain.
Okay.
But the team noticed 2 other specific clues that had nothing to do with his breathing. First, his positioning. He was rigidly upright. He was in that classic tripod position.
That's leaning forward with your arms braced on your knees, right? To help you breathe.
Correct. It helps maximize how much your diaphragm can move, and it minimizes pressure on the lungs. But for pericarditis, this posture is especially helpful.
Why?
Because lying flat actually increases the amount of blood returning to the heart. And that increases the fluid pressure, the effusion pushing on the heart and diaphragm. So when the patient is upright, gravity helps relieve that pressure just a little bit.
So his body instinctively knew the position that was least painful for his heart, not just his lungs.
Precisely. And the second clue was the quality of the pain. The chest pain was radiating into the spine of the scapula.
Into his shoulder blade.
Into his shoulder blade. And this is a classic pattern of referred pain. The inflamed sac around the heart, the pericardium, sits right next to the diaphragm, and they share nerve pathways.
Oh, okay.
Specifically the phrenic nerve. So when you irritate the pericardium, the pain often shows up in the shoulder or the back. That combination, the upright posture and the back radiating pain, is highly suggestive of pericardial inflammation.
So the detective work really begins. The clinician even reflected that she felt, frustrated, saying she never gets the textbook cases.
Nobody ever does. But that search, that relentless digging for the non-obvious cause is what saved this man's life.
And then the last piece of the puzzle just falls right into place.
The history. The clinician asked if he'd been sick recently, any viral illness. And the friend confirmed it. He'd had what sounded like the flu about 3 weeks prior.
And the clinician suspected it was a Coxsackie virus.
Which is the smoking gun that connects the entire picture.
So tell us why that timeline, that 3-week gap, is so critical here.
Well, viral pericarditis is rarely an acute thing that happens during the viral illness. It's almost always a post-infectious inflammatory response.
Okay.
The body clears the initial virus, like Coxsackie, which is usually pretty benign. but the immune system is still fired up, and it starts attacking healthy tissue around the pericardium. That leads to inflammation and the production of all this excess fluid, the effusion, inside the sac.
And the timeline of 2 to 4 weeks after the infection is...
It's absolutely classic for this phenomenon.
So the initial severe breathing problem, the thing that looked exactly like asthma, was actually being caused by fluid building up around his heart.
Yes, it was squeezing the heart and putting this immense mechanical pressure on his lungs and his diaphragm. The heart was literally being choked by the fluid, and the lungs were screaming in response.
The diagnosis had completely shifted from pure pulmonary to a lethal cardiovascular problem.
Yeah.
So now they have a pretty high suspicion, but they need hard evidence. And they're limited, right? They're in a remote setting.
Very limited. But what they found was truly alarming. The EKG was the first major confirmation, and it gave them this shocking visual.
What did it show?
It showed ST elevation in almost every lead.
Now, when most people hear ST elevation, they think massive heart attack, myocardial infarction.
They do, and they should panic. But the pattern of the ST elevation here actually pointed away from a typical heart attack.
How is that distinction so crucial?
It's all about the pattern. In a heart attack from a blocked artery, the ST elevation is localized. It only shows up in the leads that are looking at the specific part of the heart muscle that's dying.
Like the front or the bottom?
Exactly, the anterior or inferior leads.
Right.
But in acute pericarditis, the inflammation is all over the surface of the sac. It's generalized. And that causes a diffuse, widespread ST elevation across almost all the leads.
And recognizing that difference is critical.
It's everything. It tells the clinician the patient doesn't need a trip to the cath lab for a stent. They need immediate inflammation reduction and fluid management.
And the other test backed this up, the X-ray.
The chest X-ray showed a massive heart. It's the visual proof of that pericardial effusion. When the sac fills with enough fluid, the heart's outline on an X-ray can look enormous. They sometimes call it a water bottle sign.
Wow.
It gives you immediate, stark evidence of just how much fluid is in there.
And the final lab result was just as important, right?
Yeah.
It confirmed the specific nature of the problem.
Yes. His troponin levels were normal.
And troponin is the protein that's released when heart muscle cells actually die.
That's right. It's the gold standard for ruling out catastrophic damage to the heart muscle itself. So normal levels meant that while the sac was inflamed and compressing the heart, the underlying muscle was, for the moment, surviving.
So the diagnosis was acute, severe pericarditis, not a myocardial infarction.
Correct. It gave them a window to act, but a very, very narrow one.
That is just incredible diagnostic work under extreme pressure. But now they hit the logistical wall of remote medicine. You've confirmed a life-threatening heart condition that needs a specialized procedure, a pericardiocentesis, to drain that fluid.
And you are on a remote island.
Yeah.
So the PA immediately calls for the medevac, but she knows that the journey from the mainland will take at least 4 hours, and that's assuming the winds are favorable.
4 hours. That's an eternity in a case like this. The difference between survival and death.
It is. In 4 hours, a stable effusion can turn into cardiac tamponade. That's where the pressure gets so high, it completely stops the heart from filling with blood, and the whole circulatory system collapses.
And the clinician noted that she had learned how to do a pericardiocentesis in theory, but she'd never actually performed one.
That anxiety is so real. You realize your textbook knowledge is about to go up against the wind, the clock, and the limits of your own equipment. It raises that constant, urgent question for anyone practicing in a remote setting.
What do you do? How do you manage a condition that needs an invasive procedure that's hours away?
You manage the immediate threat. You stabilize the physiology as best you can.
What was the crucial bridging therapy they used while they waited for that helicopter?
They used the diagnosis. Since they confirmed it was severe inflammation, the primary treatment they needed was a massive anti-inflammatory. The patient was given 800 milligrams of ibuprofen.
Ibuprofen.
A high dose, yes. Ibuprofen is an NAID, a non-steroidal anti-inflammatory drug, and it's the core therapy for pericarditis because it directly reduces the inflammation that's causing the fluid buildup.
And thankfully that was enough. The initial stabilization, the steroids and oxygen, optimizing his position.
Right, keeping him in that tripod position.
And then the high-dose NSAID, it all worked together. By the time the medevac arrived 4 hours later, he was dramatically improved and stable enough for the flight.
It's a perfect demonstration of using what you have, accessible, immediate resources, to bridge a crisis until definitive care can be reached. They used basic diagnostics and pharmacology to buy 4 hours.
So let's talk about the resolution, the bigger picture here. The patient gets to the mainland. The cardiologist confirms the effusion and aspirates the fluid from the pericardium.
Relieves the pressure.
Exactly. And the patient was discharged a few days later, no further problems. A truly successful outcome.
It really is a textbook example of differential diagnosis in action. The key takeaway for anyone listening is that the severe shortness of breath was a red herring. It was a secondary mechanical symptom.
Right.
The real source of distress was the cardiac pressure. The body was presenting an acute respiratory crisis when the real clock was ticking on his heart function.
And I found the clinician's personal reflection so insightful, admitting to feeling the weight of being just a PA in that moment. Feeling those limitations when you're faced with a procedure you've only done in theory.
That gap between knowing and doing, especially in a crisis, is a terrifying place to be. But it speaks to that relentless drive for mastery that defines good medicine.
It does.
That feeling of hitting a personal limit, it led directly to action for her. The PA said this case was a huge motivator to go back and learn more, saying, I want to know more and I want to be able to do more.
You can never assume you know enough, especially when the textbook case never walks through your door.
Absolutely. You have to keep pushing your baseline of knowledge because common symptoms will always, always mask something rare and deadly.
The essential learning point here seems to be that link between a seemingly common viral illness, the flu, a Coxsackie virus, and these severe delayed cardiac consequences.
That's it. You have to question why your initial treatment isn't working, and you have to keep digging for that new piece of history, that new physical clue.
So what does this all mean for you, the listener? This deep dive really shows why a seemingly minor change in a patient's presentation, like just being able to speak 3 words, can literally be the difference between a near miss and a tragedy. It was that minimal, steroid-induced relief that allowed the fatal flaw in the asthma diagnosis to be exposed. The patient's heart had been suffering in silence, just squeezed by inflammation, until it became critical.
So our final provocative thought for you to think about is this. Next time you hear about someone recovering from a bad flu, consider the residual risks. The body's inflammatory response doesn't always just switch off when the fever breaks.
This case reminds us that even 3 weeks after an infection, our recovering body might still be harboring a life-threatening problem that just demands a deeper look. We'll leave that thought with you. Thank you for joining us for the deep dive.
See you next time.
You're listening to the Prehospital Care Podcast on the Medics Academy Network.